Okay, we are live. Dr. Thomas, if you want to just dive right into today's topic, that would be great.
Sure. So today we're going to talk about a very interesting topic. I read this article recently by doctors Pisetsky and Lipsky from Duke, and I just found it fascinating because it tied in to one of my patients that I had recently treated with great success, and I wanted to kind of tie everything together. Lupus, unfortunately, about 20 to 30% of our lupus patients have something called fibromyalgia. We call it secondary fibromyalgia because it's associated with lupus. And it's a horrible condition that causes severe pain, fatigue, tiredness, brain fog, difficulty thinking, and a whole slew of other symptoms. But these researchers from Duke, they recommended that we change the term from fibromyalgia to lupus associated nociplasticity. And I know that's a lot of long words to say, but I will promise that I'll define them in just a little bit, and hopefully I'll be able to convince you towards the end that this is probably a better term, and I am going to start using it in my practice instead of fibromyalgia. And then they bring up the topic of whether we should call this a type of CNS lupus. CNS stands for Central Nervous System lupus, and back in the 1990s, the American College of Rheumatology listed a long list of different types of manifestations of CNS lupus, including things like seizures, cognitive difficulty with thinking, brain fog, in other words. Um, um, Also, things like things such as disorientation uh, and just a whole slew of things. But should we include this as one of those CNS manifestations? So I thought this was a groundbreaking concept from the Duke University researchers. And this is the article if anybody would like to look it up after they watch the presentation. And you'll be able to go back and go through the slides yourself in just a little bit. But first, I wanted to introduce you to my patient, Ben. I've known Ben for over 2 decades. When I first met him, he was in his early 30s. He is truly a rocket scientist, believe it or not. But unfortunately, Ben came to me very sick with both systemic lupus erythematosus along with Sjogren's disease overlap. The disease just really devastated him. He had inflammatory arthritis. He would get sun sensitive rashes. His white blood cell count was low. But what really bothered him the most was that he had severe fatigue and brain fog. He had such difficulty thinking that he couldn't remember things in his job. And as a scientist, a rocket scientist, you could just imagine how horrible that would be. The blood work that supported his diagnosis of lupus included that he had a high anti-double stranded DNA level, which oftentimes fluctuates with disease activity in our patients. His C3 and C4 complements, by the way, which oftentimes can be low in patients with lupus who have active disease, his were normal, and that's not uncommon, by the way. 20% of our patients, C3 and C4, are not helpful because the systemic inflammation is causing the liver to churn out a whole bunch more C3 and C4, and so they're unhelpful in most of our patients. But if you've ever heard of a laboratory called Exogen, they make a much better type of complement that's more sensitive and specific in our lupus patients. And he was positive for this. He had a high EC4D complement level, and the nice thing about that type of complement is that it's not interfered with by the liver making extra complements during the systemic inflammation. And he certainly had a high EC4D level, which correlated with his disease activity. Well, I treated them with hydroxychloroquine, of course, as the first drug of choice. And over the years, I treated them with multiple other therapies, medications such as methotrexate, mycophenolate, azathioprine, Benlysta. I tried him on every single medicine that you can possibly think of. And with these different therapies, he did get better with most of them. His inflammatory arthritis would go away. His low white blood cell count would normalize. His anti-double stranded DNA level would normalize. His high EC4D complement level would also normalize, and his rash would also go away. But every time I would come into the room to see Ben, the visit always went the same. He always looked depressed. He always looked down, and he would always tell me how horrible his life was because he just couldn't remember things. He couldn't find the energy to do anything. He would have to take naps every day, and even though he slept all night long for 9 to 10 hours, he would wake up feeling unrefreshed. These were so horrible that unfortunately Ben had to go out on disability from the job that he loved as a rocket scientist. When we see these persistent types of problems like severe fatigue and brain fog in our patients with systemic lupus, researchers at Duke University, they term them type 2 symptoms. Type 2 symptoms not only include things like fatigue and brain fog, but also other problems that are associated with like depression, anxiety disorder, lack of sleep, and also widespread pain. The current thinking, or at least what most people have thought over the years since this concept was developed, is that our patients with lupus in whom all the inflammatory problems would go away, which we call type 1 symptoms. That's like his arthritis and his rash, for example. But be left with these other problems like fatigue and brain fog, the type 2 symptoms. We thought that they were probably related to depression, anxiety, and lack of sleep. And certainly Ben had these problems. He was seeing a psychiatrist and he was being treated with antidepressants and anti-anxiety medications, medicines to help him with the sleep. But with all these therapies, nothing seemed to help. I would, of course, encourage him to do things like work on his sleep hygiene, ask him to exercise regularly. Many of you watching this have heard your own doctors tell you this. How hard is it? How hard can it be, to try to force yourself to exercise when you feel horrible and you don't have any energy and you do have pain? It has to be very, very hard. But unfortunately, in modern medicine, even our tools with helping our patients are oftentimes very limited. Well, at one point, there was one medicine that started to come out recently, and that was around 2020, and that was the drug named Safnello or anifrolumab. Safnello, also called anifrolumab, it works by decreasing or inhibiting the effects of something called type 1 interferon. And we know that in lupus patients, most of them have very high levels of type 1 interferon. And so it made sense that using a biologic like Safnello to decrease the activity of type 1 interferon may help many of our patients. And it truly ended up being a very good medicine for many of our patients. So I put Ben on Safnello or anifrolumab. To be honest with you, I didn't think much about it. I really wasn't that optimistic that he would do great. When I put him on it, his anti-double stranded DNA level was high. His EC4D complement level was high. He did have active inflammatory arthritis. Fortunately, his rash was not present at the time. And then after I started him on the Safnello, he saw me just a couple of months later. When he saw me 2 months later, I'll never forget this. I walked into the room and Ben was sitting there with a huge smile on his face. Ben told me that for the first time in over a decade, he was working on chores in the house. He was working on house projects. He wasn't having to sleep in the middle of the day anymore. He had his memory back and his concentration abilities back. And I just thought that this was a miracle. And I knew it had to be because of calming down that part of his immunologic system with type 1 interferon. There's just no way that this could have been by chance that these symptoms got better with this additional medication. It convinced me that his type 2 symptoms were not due to depression, were not due to anxiety disorder, were not due to just overactive nerves, but something with his immunologic system. So next, I'd like to just talk about some of the concepts that I've been blurting out so far. And first, let's look at the difference between type 1 symptoms and type 2 lupus symptoms. So the researchers at Duke, they term type 1 symptoms to be those symptoms that we absolutely know are due to inflammation. When you see your rheumatologist, in fact, these are the things that we oftentimes concentrate on because for one, we know that these are the things that we can help with the medicines that we use for lupus. So the things like nephritis, where it attacks the kidneys, the inflammatory arthritis like he has, serositis, which refers to pleurisy, chest pain when you take in a deep breath due to inflammation around the heart or lungs. And these are the things that do respond to prednisone, hydroxychloroquine, mycophenolate, Benlysta, and Saphnelo. And also, these tend to track very reproducibly with disease activity measures like anti-double-stranded DNA, low C3 and C4 complement, and high EC4D levels, just like with my patient Ben. But then we have those type 2 symptoms that oftentimes do not get better, even in patients who are in complete remission from their lupus. Their anti double stranded DNA is normal, their complement levels are normal, but they still persist to have widespread pain, fatigue, brain fog, difficulty thinking, depression, just like with my patient named Ben. And these oftentimes don't seem to correlate at all with the inflammatory markers that we see in the blood test. So these problems, widespread pain, fatigue, brain fog, depression, they go by multiple different names. Let's say that someone has these symptoms and that the widespread pain is the biggest problem. Well, we oftentimes term this fibromyalgia. The patient will be oftentimes very tender when you just barely touch them in different places of their body. But they'll oftentimes also have fatigue, difficulty thinking, depression, trouble sleeping at night, waking up in the mornings feeling unrefreshed. And unfortunately, those of you watching this who have lupus, 20 to 30% of you do have this problem. But since you're watching this, I suspect that the vast majority, if not all of you, had this because the title of this was about fibromyalgia and could it be a manifestation of central nervous system lupus or not. But let's say that the fatigue is the biggest problem. Well, in that case, we may call it chronic fatigue syndrome, but these patients also tend to oftentimes have aches and pains throughout their body, difficulty thinking, depression, mood disorders, trouble sleeping at night. And then, of course, if depression is their biggest problem, they could be very, very depressed, satisfy the classification criteria for major depression, but depression itself can also cause pain, fatigue, and brain fog as well. And of course, we term that depression and treat it with antidepressants. But now let's turn to pain. 90% of systemic lupus patients are plagued with pain. Most of the time it's due to inflammatory pain that we can treat with hydroxychloroquine and steroids, but too many times is due to those type 2 symptoms. And it can be very helpful to look at the different types of pain. Not all pain is created equal. And by the way, all pain is in your head, by the way. You can't have pain without the brain thinking about that pain. So I just want you to think about that and keep it in mind. So let's look at 3 different types of pain. First, there's the type of pain that all of us know about, even little kids know about. It's called nociceptive pain. Nociceptive, it comes from the 2 Greek words. The nocip part refers to tissue damage, and in this case, it relates to actual tissue damage, such as the match of burning the bottom of the foot in this illustration. Ceptive refers to being receptive to something or the sensory process of actually detecting something. So nociceptive pain is when there is tissue damage actually going on, and then the peripheral nerves sending pain messages up to the brain, and then the brain interprets that pain and feels that pain, and they can knows to pull that foot away from the damage that's going on that's causing it the problem. This is a normal protective type of pain. This is the whole reason that that pain exists in the first place,
Oh,
is to
Dr. Thomas,
protect us.
I'm sorry
Yes.
to interrupt you. I just want to let you know that the slides are not on the screen anymore.
Oh, they're not.
Yes,
Oh.
if you wanted to share them, you
Oh,
just
I'm so sorry about that.
oh,
Thank
no
you for
worries.
letting me know. Let's see. And do
Perfect.
you see it now?
Yes.
Okay, very good, very good. And let's see. So would you like me to start over?
No, no, everything was great so far. Yeah, I think we're all
All
following.
right, very good. Okay, so let me just start with this going through the pain part at least. Okay, so nociceptive pain, because you need to see the terms on here. So nociceptive pain comes from oops. It comes from two Greek words, nosa related to actual tissue damage. Septive means the sensory process of detecting something. You feel the tissue damage on the bottom of the foot, pull your foot away so that you can protect yourself, and that's normal protection for you, that you know to pull the foot away. But even though there's tissue damage, the bottom of the foot probably has a burn. There's probably a blister because of the burn that happened. But our neurological system is so good at also protecting us at how we feel. The pain nerves start to calm down, and even though there's permanent damage to the bottom of that foot, the pain goes completely away at some point, and that's how pain should actually occur in the first place. And so that pain goes away, and then we feel much better as the body heals itself. Well, there's a second type of pain called neuropathic pain. Neuropathic pain does occur in people with systemic lupus. The lupus can attack the nerves and cause permanent nerve damage, illustrated by the red nerves that you see on the foot there. But there's other causes of neuropathy as well, such as diabetic neuropathy, where high glucose levels or sugar levels damage the nerves of the foot as well. And when that happens, then people can get horrible pain, which I oftentimes describe as burning pain in the foot. And that pain can fluctuate, it can come and go. It can especially occur at nighttime when the person is in bed. It can occur for no reason at all. It can just come on with a lightning type of sensation as well. And this is another type of abnormal pain. It just seems to never go away. And this type of pain, this is the one that we oftentimes will treat with nerve pain medicines like gabapentin, Lyrica, pregabalin, duloxetine, Cymbalta, and so forth. And so that's a type of abnormal pain, a different type of pain. And then there's a third type of pain. The third type of pain, and that's what this whole talk is about, is something called nociplastic pain. So nociplastic pain, it also comes from that Greek word nosa, which refers to tissue damage. But in this case, there's actually no tissue damage. There's no tissue damage, but the brain is interpreting that there's tissue damage out in the periphery through something called plasticity. Plasticity, or the word plastic, it refers to abnormal changes and misfiring of nerves in the central nervous system, as illustrated by the blue nerves that you see here in the brain and also in the spinal cord. And nociplastic pain is an abnormal type of pain that's causing pain to occur because of pain messages going up and down the spinal cord into the brain and back down into the foot, and causing pain to occur in this area of the foot, where if you were to do a biopsy of the foot, you would not see any damage whatsoever. You wouldn't see any damage to the cells, but the nervous system is thinking that there's damage going on there. And this is the type of pain that we see in our patients with fibromyalgia. Fibromyalgia is a type of nociplastic pain, and it's an abnormal type of pain. So fibromyalgia is a condition that causes diffuse pain, fatigue, non-restorative sleep. The person will wake up in the mornings oftentimes and feel like they didn't get a good night's sleep, even though they slept all night long. Brain fog is very common, with difficulty sleeping, mood changes, feeling depressed, temperature sensitivity, feeling cold when other people feel normal, feeling very hot when other people feel very normal. And you look at the person and they look perfectly healthy. They look perfectly fine. And unfortunately, some healthcare providers think, oh, it's probably all in her head. And I'm sure that many of you watching this have been told that before by your physicians. But is it really all in this person's head? and it is not in her head. We have a lot of objective evidence through research that there's a lot of abnormalities going on that we can actually measure in the research situations. For example, on MRI scans and PET scans of the brain, we can see increased activation in the thalamus and the insula and in the cortex of the brain, and also we even see reduced gray matter as well. There's abnormalities of CNS neurotransmitters. Nerves actually talk to each other by secreting chemicals called neurotransmitters that go from one nerve to another to tell the other nerve to become either more active or less active. And that's how we can transmit those pain receptors, for example, from that burned foot all the way up to the brain, so that we notice that there's our foot is being burnt. For example, glutamate and substance P, those are neurotransmitters that increase pain perception in the brain. And in fibromyalgia patients, there's too much glutamate and substance P in the central nervous system. But then there's other very important neurotransmitters like serotonin, norepinephrine, and GABA, which are important for decreasing pain perception. For example, going back to the normal pain, the nociceptive pain, the pain that protects us. This is the reason that when you burn your finger, it's very, very painful. The glutamate levels, the substance P levels go up. You pull your finger away from the source of the damage, but we don't want our finger to be hurting all the time. So serotonin and norepinephrine and GABA increase in the brain to calm those pain receptors down, so that we're not miserable and we can let our finger heal up over time. But in fibromyalgia patients, there's a lack of serotonin and norepinephrine and GABA. So the pain nerves are overactive and they're not calmed down like they should. And this is also one reason why some neuropsychiatric medications like antidepressants and anti-anxiety medicines, for example, duloxetine or Cymbalta, can be helpful with people with fibromyalgia and other types of nociplastic pain, because it can help reverse these types of neurotransmitter problems. But these truly are going on in people with fibromyalgia. And then there's sleep study information, which is fascinating. When we do sleep studies on people with fibromyalgia, they may look like they're in the deepest parts of sleep, called non-REM sleep, but on EEG testing, we can actually see evidence of alpha wave intrusion. Alpha waves are the type of waves that we should only see in people who are completely awake. So even though they look like they're asleep, they feel like they're asleep, they're not getting a full night's sleep. They wake up in the morning and feel unrefreshed. They even did a study, by the way, where they took normal, healthy people, let them fall asleep, but they kept slightly waking them up and causing these alpha wave intrusions artificially, and those people actually developed diffuse pain and fatigue simply by changing how their EEG looked by causing those alpha wave intrusions artificially. So fibromyalgia is not in someone's head; it is in their head, and that the brain nerves that sense pain, of course, are feeling the pain going on, but there's a lot of objective evidence that there are truly abnormalities going on. So it is a very complicated problem. And by the way, fibromyalgia is the hardest thing for a rheumatologist to treat. It's one of the least understood disorders. We have horrible treatments. Certainly there are people who do respond to the FDA-approved drugs like Cymbalta, duloxetine, pregabalin, and Lyrica, and do wonderful in them. But the vast majority of our patients don't do very well. It's one of the biggest unmet needs in rheumatology. We need to understand more about it, and we definitely need better treatments and hopefully find a cure for it someday. But it's interesting that there's actually evidence that fibromyalgia may actually have an autoimmune component to it. And this was a fascinating study published just a couple of years ago by Dr. Goebel and his associates, and they called the name of their study "The Passive Transfer of Fibromyalgia Symptoms from Patients to Mice." Up to this point, We always just thought that fibromyalgia was just due to uh, increased sensitization of pain in the brain and overactivity of the peripheral pain nerves, and it was a nervous system problem, but we didn't know why it was happening. Well, these doctors, they did something very interesting. They took humans with fibromyalgia, drew blood out of them, and then they isolated the immunoglobulins. Immunoglobulins are antibodies, and they isolated the antibodies from these fibromyalgia patients and then injected them into healthy mice. Now, in mice, you can actually measure how they perceive pain. And one of those ways to do it is by taking the paw of a mouse and putting it on top of an ice cube or something very cold. And then you time how quickly the mouse takes its paw off of the ice. And there are certain norms that you look at healthy mice, and there's a certain amount of time that they typically do that. But in the mice that received the immunoglobulins from those fibromyalgia patients, they were quickly removing their paw off the ice a lot faster, showing that they had increased sensitization to temperature as a noxious stimulus. And the only difference was because of the immunoglobulins that were injected to them. The healthy mice that were the placebo group, they had normal reaction times. But there was another interesting test that they did. Another test that you can do is take the mouse and put the paw within a clamp and just very gently squeeze on their paw with a certain amount of pressure. And at a certain point, the mouse will pull its foot away from the clamp. And this is also standardized that they do that within a certain amount of pressure and in a certain amount of time. They did it on the healthy mice that was a placebo group and compared it to the ones who got the immunoglobulins from the fibromyalgia patients. And the mice with the immunoglobulins from the fibromyalgia patients pulled their paws away a lot faster, showing that they had markedly increased sensitivity to noxious stimulus. In other words, fibromyalgia-like symptoms simply by receiving these immunoglobulins. They then went a step further to ask the question, well, these antibodies that are from the fibromyalgia patients, what are they being directed towards? And what they showed is that those antibodies were actually directed towards satellite glial cells, which are found around the spinal nerves that come in and out of the spinal cord. And these antibodies that would be directed towards these satellite glial cells were actually causing increased pain. So here we have evidence that fibromyalgia can actually possibly have an autoimmune basis. And this was really a landmark study in showing this. And it shows, one of my favorite sayings is the more you know you don't know. And this was one good example of it, is the fibromyalgia connection between lupus and autoimmunity. And unfortunately, up to 30% of our patients with lupus do have fibromyalgia, which is far higher than the general population. The general population, it's about 2 to 5% of the population. So this high prevalence of fibromyalgia suggests that there is a direct connection between fibromyalgia and lupus, pointing to some shared underlying mechanisms rather than coincidence. In other words, the abnormal immunologic system must be contributing to these abnormal pain perception pathways that we're seeing in our lupus patients. There's also some other evidence that there's other reasons or possible reasons why lupus patients may be having these fibromyalgia symptoms. And we found through multiple studies that there are immunologic abnormalities in lupus patients who have brain fog, fatigue, mood disorders, diffuse pain, and other CNS or central nervous system type of symptoms. Inside of the central nervous system, we found that there are antibodies like anti-ribosomal P antibody, which is directed at certain nerves, anti-NR2, which is a type of anti-double-stranded DNA, specifically DNA that's located within neurological cells. Anti-Rho, anti-U1-RMP, anti-cardiolipin antibodies, these have been found in much higher amounts in people, lupus patients with these types of problems. Interferon alpha. Remember I mentioned that my patient Ben, I treated him with a medication that calms down interferon, and he had a marked response. Could this be the reason why he did so well? Was it because it inhibited his interferon that might have been too high inside of his brain and possibly causing the fatigue and the brain fog that he had? I think it probably did. And by the way, I'm not suggesting in any way whatsoever that people with lupus and brain fog and fatigue that are not getting better should all get Safnello. It has not been proven to do this in everyone. I haven't seen it in anyone except for Ben to this dramatic of an effect. But when you look at the clinical trials, overall, patients do have a better quality of life. Less fatigue is part of that in the Safnello trials. But also there's cytokines. Cytokines are a way that immunologic cells talk to each other by sending different molecular messages to each other. And we know that there's abnormalities of different interleukins like interleukin 6, interleukin 8, but also other cytokines like IP10, MCP1, GCSF, and CCL2, just all fancy abbreviations for different types of immunologic abnormalities that we see in lupus patients inside the brain that are associated with these types of problems. So the question is, if we have someone with lupus who's having horrible brain fog, fatigue, increased widespread pain that's not responding to other therapies, which of those patients could possibly be having these particular types of immunologic abnormalities? And could we find immunologic drugs that could possibly reverse these problems so we could help these patients out? And that's where these researchers from Duke were suggesting that fibromyalgia-like symptoms in our patients with lupus are probably not just due to the abnormal immunologic or the abnormal neurological system that we think about with regular fibromyalgia that is not associated with immunologic problems. Maybe some of them could be due to immunologic problems like abnormal antibodies and cytokines. So they came up with this term called lupus-associated nosoplasticity. Lupus-associated, they wanted to call it lupus-associated nosoplasticity instead of fibromyalgia because fibromyalgia and it just insinuates that it's just a nerve overactivity problem, but doesn't address some of the other things that could be causing it, like the immunologic problems. They want to say that lupus-associated nosoplasticity deals with persistent type 2 symptoms related to central nervous system sensitization, altered pain pathways, but it's a lot more than just beyond pain. It also includes problems with fatigue, like my patient Ben, mood disturbance, like my patient Ben, brain fog, like my patient Ben, and sleep disorders as well. But also it incorporates that it's disease specific, that these symptoms are directly tied to the lupus abnormalities or the lupus pathogenesis as well, and not just a secondary condition, which we should just be throwing gabapentin and duloxetine and Cymbalta at the patient, but maybe there's other therapies that could possibly help. It could be due to neurological overactivity, of course, like patients who have fibromyalgia and don't have an immunologic problem, but it could be possibly directly related to the abnormal immunologic activity. So there are some clinical implications of Dr. Pazetsky's and Dr. Lipsky's and the researchers at Duke with this lupus-associated nosoplasticity. First of all, calling it this instead of secondary fibromyalgia lets healthcare providers and clinicians know and recognize that lupus-associated nosoplasticity should be considered a neuropsychiatric manifestation of lupus. Right now, it is not listed as a neuropsychiatric manifestation of lupus, but I agree with them that it should, because look at my patient Ben. He actually got better with treatment of his lupus with that Safnello. We should be able to figure out somehow how to identify these patients. There was no way I could figure out that Ben could have possibly responded to Safnello and had these his brain fog and his fatigue go away. We need to do a lot more research to try to figure out, what are there specific activity measures and patient-reported outcomes that could possibly help us identify, if the symptoms are due to immunologic problems or due to just some nervous system overactivity. And then we can know how to treat it properly using therapies like tricyclic antidepressants, exercise, stress reduction for those patients in which it's the nervous system activity, overactivity alone that's the cause, or should we be using directed immunomodulatory therapies directed specifically at those immunologic abnormalities? We have a long way to go. The bottom line is that we need much more research to figure this problem out, and so that's hopefully someday we can have more patients do much better with these symptoms, like my patient Ben. And I just wanted to bring up this topic because I thought it was fascinating. I do plan on identifying these problems in my patients as lupus-associated nociplasticity instead of fibromyalgia, because I want to signify in their charts that there's the possibility that they could possibly get better with treating their lupus better, and not just that blaming it simply on the neurological abnormalities. I don't know what to do yet because we're not there yet with the research, but I'm optimistic that hopefully in the near future, better therapies will be found. And I appreciate you having me here to talk today. I apologize for the first slides not showing up, but I hope that I was able to make myself clear and understandable. And sorry to throw out all these fancy words, but I hope I was able to make them more understandable.
Definitely. That was so fascinating to hear about like the changes with fibromyalgia. I think I know we have a lot of questions about this. I think some of them you already answered a little bit in what you covered, but if you have a second, I'll ask a few of the Q&A questions that we have here.
Sure.
The first one is, how come so many of us get diagnosed with fibromyalgia? Is it just overused if doctors don't know what to say? And I feel like you answered that a little bit across the course of your talk, but
Sure. So one thing is we do have classification criteria and even diagnostic criteria for diagnosing fibromyalgia, and this has been these measurements and diagnostic criteria and classification criteria have been validated in the research by fibromyalgia experts. So most of us, we do go by these criteria to help identify fibromyalgia in our patients. But still, as you saw from my talk, there's so much more that we don't know about fibromyalgia, and we just need to learn a lot more about it. Part of it is that we don't know what's going on, and so that's absolutely correct. So we have a lot more to learn in modern medicine. So yes, I just always know that the more I know I don't know, and I know when I can diagnose fibromyalgia and when I should, but I don't know what to do a lot of the time, unfortunately.
thank you, Dr. Thomas. The next question is a rheumatologist the best person to diagnose fibromyalgia, or do you have to see a neurologist or a pain specialist?
All of those are actually can be very helpful. Like the Association of Pain Medicine, they had their own definition of how to diagnose fibromyalgia, for example. But primary care providers, neurologists, pain management specialists, and rheumatologists. I think that all four of those are the experts that are most qualified to probably diagnose fibromyalgia accurately in a patient.
Okay. If I've been diagnosed with fibromyalgia and lupus, should my treatment plan have both immunosuppressants and the nerve medications like gabapentin?
That's a tough answer because we really don't know.
Okay.
We certainly have medicines like gabapentin and Cymbalta, duloxetine, pregabalin, amitriptyline. These are all medicines that we use to treat fibromyalgia, tramadol even, and it's a crapshoot, to be honest with you. We never know which is going to be the best one to use in any particular person. But interestingly, every single research study that's looked at the treatment of fibromyalgia and their treatment over a long length of time, there's only one treatment that has been regularly shown to be the most effective, and that is exercise. And and I
Wow.
know it has to be frustrating as a patient. You I know you have to hate it when your doctor is asking you to exercise more when you feel horrible, you're in a lot of pain, you're too tired to exercise. But I will say that my fibromyalgia patients who finally force themselves to exercise and exercise regularly, they do come back feeling better. And I would like everybody to think about this. Think about a time in your life back in the past when you were exercising regularly and how good you felt. And then something happens, a stressful situation, or you went on vacation and you stopped exercising. Then all at once you feel fatigued and achy again. There's definitely a correlation there. And one of my favorite recent research studies, by the way, was a research study at the National Institutes of Health, and they published this a few years ago. They took sedentary women with systemic lupus and horrible fatigue. Half of them, they forced them to exercise. They made them go to the NIH and actually supervise them doing really hard exercise on a bicycle 3 to 5 days a week. And then the other half of the patients, they just let them do whatever they wanted to do. And then after 6 months, the ones who were forced to exercise, who felt horrible, had horrible fatigue, they had significantly better qualities of life and better energy levels at the end of the study. But something very interesting that they demonstrated, there's a huge problem that we're identifying in our lupus patients and Sjogren's patients and other patients with autoimmune diseases, something called mitochondrial dysfunction. The mitochondria are tiny microscopic organelles that are found in every cell of the body except for red blood cells, that are the powerhouse of the cell. You need mitochondria to actually make energy inside the cell. And we know that in lupus and Sjogren's, that these mitochondria are actually dysfunctional and don't work normally. And what they showed at the NIH by Dr. Hosny and his group is that there was mitochondrial dysfunction in all the patients at the beginning of the study, but then at the end of the study, they had their mitochondrial dysfunction was significantly improved, and the only intervention was exercise. So the exercise, it absolutely is doing something positive, feels physiologically to people when they do it. But of course, the hard part is making that first step to do it. But I hope we can find easier treatments because it is hard to force people to exercise.
Wow, that's so interesting, that whole study. Thank you so much for sharing that. I know that it can obviously be really challenging for certain parts of the patient population to do so, but that is really helpful information. Our next question here is, are there any supplements to help normalize the CNS neurotransmitters that you listed that can help, or is that not a thing?
Yeah, unfortunately, it's not a thing. Everything that I showed you on that one slide, as far as the PET scan abnormalities and the neurotransmitter abnormalities, that even the cytokines and the antibodies, unfortunately, those are things that can only be done at this time in research. And that's why I'm talking about that. And the Duke researchers that came up with this paper, they're talking about that. Hopefully, we can get to the point where these types of things can be translated into clinical practice, to where someone like myself, that I could potentially and hopefully be able to measure something like this in my patients and be able to identify, what abnormalities my patient might have, so that maybe I could have an actual therapy out there that I could direct towards that particular abnormality. We call that personalized medicine. It's something that all of us rheumatologists, have this dream of hopefully having in the near future. Hopefully it will, and but it's not. We're not there yet.
Okay. I'm seeing a few different questions about like related to differentiating between like the symptoms of brain fog and other things related to like a lupus flare versus like fibromyalgia or like a type of CNS lupus, and also questions about whether or not your doctor might know about LAN, or like or be aware that this is possibly lupus involvement. Do you get the sense that most rheumatologists would know are thinking this way, like the way that you're describing, or is this newer information that maybe a patient might need to bring up to their doctor?
Yeah, this is such brand new information that I guarantee you that the vast majority of rheumatologists don't know about it, and the reason for that is that we just have way too many journals out there for rheumatology, way too many research articles, and just for example, I read all the lupus literature. That's how I know about this. But like psoriatic arthritis, I have no time to read all the uh, even a small part of the psoriatic arthritis literature. The same thing with ankylosing spondylitis, osteoporosis, rheumatoid arthritis. It's just humanly impossible for a rheumatologist to know all that. So the vast majority don't know about it. These are the kind of things that we would teach at our large American College of Rheumatology meetings, and try to hopefully get this information disseminated out over time. I think it's going to be a very slow concept to catch on. Those of us who specialize in lupus will probably be the first ones to start using this and start teaching about it. But hopefully, it will catch on in the long run.
Great. Do you have any advice for the patients that might be experiencing these symptoms and more, prominent symptoms of what they feel is fibromyalgia and are curious about it potentially being lupus involvement? Do you have any advice for them bringing that up to their rheumatologist?
Unfortunately, I really don't. When I came up with this talk, I was trying to think of whether I could give practical advice like that, but I
Sure.
really can't because we just don't have the research into it to even know what to do with the information at all. Like my patient Ben, if I saw him for the first time today, it be maybe 20 years from now before I would have found this therapy to finally help him out, just for example.
Okay.
So, yeah, we just don't know how to identify it and what to do about it. But I'm just identifying it that this is a problem with a potential treatment and a potential way to solve it at some point, and that
Sure.
there's optimism in the future.
That's great. Thank you so much. We really appreciate your time, Dr. Thomas. We'll link to all of Dr. Thomas's socials and websites so that you can follow him and stay up to date on all the talks that he's giving. And of course, I'll put the link in the comments so that anyone who wants to sign up for joining our community to get notices when Dr. Thomas is going to speak can do so. So thank you so much.
And thank you for having me.